And ladies and gentlemen, it's indeed my pleasure to be here. We are certainly busy dealing with Ebola, but the life goes on, and Ebola has been proving much tougher than we initially thought. So I think we are switching the gears from local politics to the global politics. And my outline of my presentation is like, what is the challenge if you want to really work on policy and the research? And the case is these are two different words. What are the realities and why it is so complex? And then what is the prevailing mindset? And then realization of the complexity. And is it possible to bridge this gap between researchers and policymakers? And when I say policymakers, it does not mean the people sitting in the ministries of health only, but these are policy and the decision maker either at the federal level, state level, or even at the program and the implementation level at the districts. So my presentation is not going to focus entirely on Switzerland. It's primarily focusing on low and middle income countries, but there are issues we can certainly have learning for the north, including Switzerland. Okay, so this is like an old quote, but still it stays the same. The evidence frequently fails to inform policy and practice, and when we say evidence, it includes scientific research, but it's not the only scientific research. But the research, which is primarily scientific, the research agenda fails to respond to policy needs. And there's a lot of literature, we have it, which says, and the reality is, like research, when we commission, conduct, and do, and most of you are in the academic setting, and I had the pleasure to be in academic setting for a long time, there's a reason we join academia and the research organization, because we want to apply the mind and the thinking we have, and we want to test some sort of the hypotheses or the question we think are important and can help to improve the population health. But in public policy making, many suppliers and users of social research are dissatisfied. The former because they are not listened to, the latter because they do not hear much what they want to listen. And I will give you like this, like some of you, we have been like presenting this like diagram or the figures. Some of you may have seen it, so apology again. So this is somebody in the balloon, and they say, where am I? And the answer comes, you are 30 meters above the ground in a balloon. Oh, you must be a researcher. And then they say, yes, how did you know? Because what you told me is absolutely correct, but completely useless for me. Okay. Then he said, you must be a policymaker. Yes, how did you know? Because you don't know where you are, you don't know where you are going to, and now you are blaming me. And that is a harsh reality, not in many settings, not in like the democracy as an important function of raising and contributing the voice and providing evidence. But this remains a challenge in many parts of the world, but including North. So who are the different stakeholders for different types of research? There's like a basic research, there's a clinical research, there's a health services research, and then there's population health. So there are patients, there are professionals like health professionals, local administration, national policymakers, regulatory bodies, industries, research funders, researchers. So most of the interest is in health systems research, and within WHO, we have moved the word from health services research to the health systems research, but primarily still, especially in Canada, Europe, and North America and Australia, researchers primarily use the word health services research. And since the Jim Kim has become the president of the World Bank, he is calling delivery science. So that is what he wants to take. Instead of health services research, he calls it a delivery science. But what the point I'm trying to make, you have to just see who are the stakeholders when we want to make the decisions. And then the reality is, What works, which is primarily intervention effectiveness, is known, and there are adequate methods for summarizing this evidence. And I was talking to a colleague this morning. I'm a physician by training, but then I had a PhD from Johns Hopkins. So what is happening, most of us who are in the public health, they are medics, and they are conditioned into something which we say, no logic in your life. You have to remember and memorize. The artery goes from here, the vein goes from here, the nerve goes from there. So that's a mindset with which most of the public health people still come into the public health. From the medical schools, we go to the schools of public health, and then we are conditioned in the epidemiology and statistics. And that's our second coat of conditioning, which takes away most of the logic, and we are like trained that the gold standard in biomedical basic clinical research is randomized clinical trials. And they are excellent. If we are looking something, you take a statin, your blood cholesterol will go down or won't go down, and we say, fine. But if you want to test a policy, or you are not testing a hypothesis, you are trying to solve a problem, and there it is not a randomized clinical trials or the effectiveness which we use the meta-analysis, the systematic reviews, which are very robust, very rigorous, and we can perfectly do it. But when we try to do, it is policy research, system research is transdisciplinary or interdisciplinary, where we have to apply, yes, epidemiology, statistics, but more economics, more public policy, more social science. But most of the time, we have to apply these all together to solve that problem. And most of us are not trained in that discipline because our funding stream, if you want to write a proposal which is multidisciplinary, there's no funder who is going to give you the money. So the incentives are not there. So what is needed is evidence on how to make what is possible in theory, a reality in practice, health policy and systems research. That is what we think it is. Understanding why and how things work is less clear, and less agreement on one constitutes evidence on this. So there's a very little science. We have a lot of science on effectiveness, but very little science if it has worked, how it has worked, and why it has worked. So, and then I think the context is very specific. The things which has been proven effective in, let's say in India, they may not be necessarily effective in China, or something it has proven effective in Brazil may not be equally good in South Africa. So existing approaches for summarizing evidence on what works is not suitable for evidence relating to issues of implementation and scale up. So that's another issue. And I will give you a very simple example, vaccination coverage. There's no rocket science required to have the children, mothers vaccinated. Still, in many parts of the world, the vaccination coverage is from 30 to 60%. Why it's not happening? Because we don't understand the dynamics, how the systems operate in that specific setting. Or if we have done something in a particular setting in that particular country or area or the population, we don't know how to scale it up. And that's a very different science. The effectiveness trial, efficacy trial, we know perfectly. How can we scale it up? That takes a little bit different science, and that is the limitation and the challenge, but that's a harsh reality that we are not able to scale up many programs which have been proven effective at a efficacy or trial level. So there's also a reality that the substantial knowledge base exists, be underutilized to improve the health of the population. There was an article, I think like 10 years ago, which claims, it was in Lancet, and I don't know who wrote it, but it says, if we apply the proven effective intervention at this point, we can save up to 64% of maternal mortality and up to 74% of child mortality. We don't have to do anything additional, but still we are not able to apply it. And that is where I think we need systems research and we need policy research. So research policy interface highly complex, and I will come to it later in my slides, particularly in low-income countries. And as I said earlier, research is biased in favor of biomedical sciences and public health intervention with significant disease-based implications. But I wrote this slide a few days ago, but I think Ebola has completely changed the definition of the health system. Historically, you will meet somebody and somebody will say, I'm a health system specialist, and then there's a colleague who will say, I'm an infectious disease control expert, or I'm an infectious disease person. Now, infection control, laboratories has become an integral part of the health system. If we don't understand this thing, system is not going to work, and it has failed in Liberia, it has failed in other countries. So that thing, the system, the new reality is going to be very different. What do we exactly mean by the health system? WHO over the last 10 years has promoted that 6 building blocks, which we think has done more disservice than really bringing together. It verticalized all those 6 building blocks instead of bringing together the whole systems approach. And then last, researchers and policymakers are 2 different groups with different backgrounds, different incentives, and with different roles and responsibility. And I have an additional slide which I will show you later. So this is a slide which is from the 2010 World Health Report on healthcare financing. And some of you may have contributed to that report because it was on healthcare finance. But you just see millions miss out on needs health services, and this is simply showing like there are like proven effective intervention, but still millions are dying. So this is almost the same slides. The inefficiency example, median price ratios of public sector procurement prices for generic medicines by WHO region, and you may know like WHO has 6 regions, like headquarters in Geneva, but there are other 6 regions in Africa, Asia, America, and Western Pacific, and Middle East. So I'm just like emphasizing the point I was trying to make earlier. And this is like historically the health systems has been designed and how they have evolved. Still, almost all health systems, including South, like we are talking about health promotion and prevention, NCDs are like chronic diseases has changed completely the situation, but still most of the hospitals and the infrastructure is designed over the germ theory infectious disease model historically. This is based on the service than the need, and like it does not necessarily consider what are the needs of the population, what is the like the epidemiological profile, what is the like the demographic profile. We just construct those hospitals where we can say these are the services we are going to provide in that particular area. And health workers trained and incentivized in treatment intervention than health prevention and promotion. And as I said, I am myself trained MD, and I can those of you, if you are sitting here, some of you are MDs, the textbook of medicine and surgery we were taught in 1981. I think my professors who went to the medical school in the 60s, they had the same textbook, and the students who are going to the medical school at this point, they have the same textbook. So nothing has changed. But the demographic profile and the epidemiological profile has completely changed. People still go, and the doctors and the healthcare providers still believe our job is to give the pills and injection and do the operate and then treatment. While they're going, we say, okay, you should have a good diet, do some exercise, but that's just a passing remark because we are not trained for that. We don't understand how can we do it, and the population does not understand. They come to the hospital to get the pain, like a pill or injection to get the pain relieved. Not go there that we are going to have a better health when we are not sick. So when I was in the Ministry of Health, I was at a senior policy position, and I said instead of Ministries of Health, we should call them Ministries of Sickness, because that's what we do. We don't do anything for health. We just do like, how can we treat it? And so health is more than Ministry of Health. That's another harsh reality. How much, if you really want to bring a change of the population of health, is it the only Ministry of Health? Road safety in many parts of the world, road crashes are now number 2 or number 3 cause of death and disability. Food industry is playing a significant role in causing or controlling obesity. Like media plays a significant role, and these are different ministries, these are different like entities in the government or the civil society, which has to play a role, but still our focus is like, as I was introduced, I work for WHO. We still deal, because it's a membership organization, only with the ministries of health, but we still try to promote that there should be like health in all policies, but that's only on papers. Okay, what is the prevailing mindset? Most of health researchers are medics, as I said, and then trained in the schools of public health. Gold standard is like RCTs. And then there's an issue of generalizability. Whenever we do research, this is one of the things, the research, what is good research, which like is peer reviewed, and we can say if you do it, you can generalize your result. It's not specific to that thing. And in policy and system research, it's very hard to generalize your results because it's primarily relevant to that particular context. When the context changes, the situation changes. And then there's also bias in training of editors and reviewers of the medical journals in biomedical and public health. I don't know how many know Richard Horton, who is editor-in-chief of the Lancet. I think he is a good friend of mine. So I have challenged him many times because he writes on the politics of public health, on global health, every second month. But I asked him why Lancet does not accept the papers on policy and the systems research. And the simple reason is the reviewers of the Lancet are very good to review the biomedical and population health and the clinical studies, but they don't have a clue how to review the policy and the systems research, because they think, oh, this is a lousy paper, common sense. What is this? It should be in the newspaper, not into the Lancet. But that is like, so there are biases. And then they control, they are the gatekeepers. If you are writing something and you are planning to publish into the Lancet or the BMJ, you have to read the mind of that editor. What is he or she is going to like consider and publish it? And that creates another barrier because they are still focused on biomedical and public health. And then, as I said, they are focusing on hypothesis testing rather than problem solving, and most of the policy and systems research is problem solving, and are at least the issues which are raised by the policymakers or the decision makers. This is a slide which we have like looked carefully. What are the really different words, researchers and policymakers? So what is the overall goal of the researchers? And I'm sure most of you sitting here are researchers to advance science, which is great. It's not either or. There's no like we are saying this is right or wrong. That's not the purpose. But it is a very different goal of two communities of researchers and policymakers. So what is like researchers generally like to have tenure track positions and publication because that's their recognition, that's their respect. If I have a friend, I come across an elevator and say, oh, I saw your article in Lancet, great. And he or she is very happy that she has got that appreciation. And that's a recognition. But for policymakers, I don't know how many you are sitting here has ever worked in the power or policy corridor. Nobody reads Lancet. I can tell you, nobody. It comes officially, they pay, they subscribe, and there's a big shelf on the back of them. It's properly put by their private secretaries. And it's every day, the month they get it, nobody reads it. They love to read like Newsweek, Economist, and if there's something there, even about Ebola, it gets attention much quicker than anything which is published. But that does not mean we don't have to publish in the Lancet. The science still has to be published. And that's a perfect place to publish the science and scientific article. But the issue is, if we really want to make this science, which we are working very hard, we are generating that additional body of knowledge, who is using it? We have to see who is ultimate user or the beneficiary of this research. Because we get the money from the public exchequer. It is not that we are investing from our own pockets. So it helps the clinical and biomedical side, but it's the translation, transformation of that knowledge so that it could be used by somebody sitting at the district level or policy level, either in the state government or at the national government. And There are other things, like there are like different issues. There's a time factor, there's a like desired outcome, and there's an issue of accountability. Who are we accountable to? The politicians are accountable to very different constituency, and the researchers are accountable to a very different constituency. And that is that, I think that is, it's not they blame each other, but they don't, but they think this is not my responsibility. For 2 years, I was regional advisor for research in the WHO Middle Eastern office. So I went to Saudi Arabia, I made a presentation, and there was a big professor who stood up and he said, I have published. If somebody wants to use it, doesn't use, not my problem. Why should I worry about it? So he was very candid, very clear. He said, why are you saying like we have the responsibility? It doesn't affect my career. I don't have any incentive. I don't have any skills. Why should I do it? So, but we are trying to preach that there is a role, there is a responsibility, and we think there are people changing. And I can tell you at least there are 3 universities we are working: London School of Hygiene and Tropical Medicine, Johns Hopkins University, Harvard School of Public Health. They are changing the appraisal of their faculty. If you are contributing to change into the policy, it would have some weight. It's not exactly a publication where they are considering, and University of Peking in China is also like, these are all their pilot testing these things, how it could be used, because it's very difficult to quantify. Peer-reviewed publication is much easier. It's peer-reviewed domain, no issue of quality, it is perfect. But if you say, I have worked with the Minister of Health or a district health officer, what did you do? 2 meetings, 3 meetings? It's very hard to measure that change and that attribution or the contribution. So there are some methodological challenges for recognition of your, like any researcher's contribution to the policy. So health systems are complex, and this is a true like causal pathways in a district in Tanzania. So if you really want to say, it looks like a very complex sewerage system somewhere under a city, but it is like a medicine technology procurement system. But you can see how many players, how many hurdles, and how many points one has to tackle when trying to do these things. So it looks simple, but there are things like we all want to have the simple things, but the reality is very different. Okay, the other is all health interventions have a system-wide effect. That's the problem. If you make a change in the system, like if you want to hire a person as a doctor, then you have to worry where his or her salary is going to come. Then what is the job he or she is going to do? Does she have some sort of like managerial responsibility? So there's always a dependence on different factors within the system, and as these things go, it becomes more complex and complex when these things happen. And this is a genuine, you know this gentleman, right? Okay, so this is a genuine answer he gave to a press reporter, and if you read it, take like a few seconds, and you will read, what is this? He's the former defense secretary of the US. So if you read it, you say, what is he talking? He says, there are known knowns. There are things we know. We also know there are known unknowns. That is to say, we know there are some things to do what to know, but there are also unknown unknowns. So it looks like, but he was a Secretary of State, and it is still, if you want to go to the YouTube, and there's a video where he's answering these things. I have not made it up. But how come, so what is this answer? So he's this is the way the politics is. So if you are listening as a researcher, you're never going to see him again. I can guarantee that. So this is another true photo from, it's not from Switzerland, but it's from Europe. So these are cycle lanes. There are 4 photos, and these are the cycle lanes. So this is somebody has worked very hard and then said, this is the policy in place. And so there it is complex. It's not easy. I'm sure they've done a lot of research, how to design it, how to put the photos, all those things. Still, it's not working. It's not going to work the way they're doing it. So here is other issue is the language we use as researchers. We are trained. We are perfect. We understand those R scale, Z test, T test, everything. For policymakers, they have a very different language. So this is a peer-reviewed publication. If we say English language newspapers are the easiest to read, then cell biology, you can see it's like most difficult, then Nature, Scientific American, New Scientist, and there's like a skill, like just reading it. And then you can see like fiction and all those are much easier to read. But that is a true like sort of a problem. Sorry, I took it quickly. But the reality is, like, we do understand that language. And the point I'm trying to make it, when we try, some of you may have the desire, I'm sure some of you have the desire that you want to make your knowledge useful to the policy and the decision making. But I think the language we use, they don't understand it. And then we say, oh, they're lousy, they don't want to listen, they don't want to hear. But there's a real problem of language. So this is like another slide, which is from like Bangkok. And if you see, like there's almost the same question asked to the researchers and asked to the public and the healthcare providers. The answers are different. The one group, the researchers are saying infections, addiction, violence. Others are saying sanitation, flooding, access to health services. It's just a very different perception. Who do you ask? And I think that is also important while we are setting our research questions, not always, but if we think it will have some repercussion for the population, we really need to talk to the people who are going to be the beneficiaries or users of that like evidence or the research. And then we always worry about, as I said in the beginning, the peer-reviewed is the best because there's no issue of quality. The quality is guaranteed because the peers has reviewed, and there should not be any questions or the challenges. We control all the biases. But whose perspective? These peers are looking only on the methods. Like, we primarily look the methods is right, and the results are okay, that's fine. We don't look like if it's going to be like useful for somebody or not useful. That's not the primarily our like purpose. And that's the relevance and the responsiveness. And then external validity and generalizability versus context specificity, as I said earlier. We look those things which are taught into our science, and if they're okay, we say, we give the good score, and we say, we recommend as a reviewer that you can publish it. And then we have to say, like, how are we learning and knowing the knowledge generation if we really want to use it? And that's a very different quality lens than if we're just looking at the methodological rigor and the robustness of that article or the research. Okay. The other is, how do we find the evidence? Peer-reviewed publication represent a small fraction of the total intelligence related to implementation that exists. And that's a fact. I have worked in a power corridor in the Ministry of Health as Assistant Director General and Deputy Director General. At that time, we thought we are the astronaut, we know everything. We don't have to talk to anybody, which was silly. Then I went to an academia and I thought, we know everything, they don't understand anything, we don't have to talk to them. But I think there's a need to bridge that gap. There's a need to understand how policymakers operate, how they behave, and they're very different. I said their incentive, their careers are very different. Same, they have to understand how can we get some sort of like good intelligence of the evidence from the research community, but that has to come there. But that's a very, very different, like, I think the incentives are very different. And then I think the rewards are very different, the appreciations are very different. But also research published in the peer-reviewed domain is not the total evidence which is used for policy planning and the management decision. There's a gray literature, monitoring report, like commissioned reports, which are not into peer-reviewed domain. And there are also, like, people say, what do I think about this thing from my peers as a policy and the decision maker, or any other source of information which may not necessarily come from the peer-reviewed domain. This is another slide from a person who was policy advisor to the Parliament of the UK on the social policy. And if you read it, the research evidence comes on number 9. This is ranking he has given. He's still alive. So if you look, so his name is there, Phil Davis is there, he was deputy chief of the social research there. So he says expert evidence, opinion-based evidence, ideological evidence, party think tank manifestos, media evidence, internet evidence, lay evidence, street evidence, even cabbies, they matter. When MPs are going to the parliament on the cab, they ask them, oh, how do you think the government is operating? And that helps, like, or affects their mind. Research, important, but it comes. But the point I'm trying to make it, some of you or some of us who are interested to work with the policy and decision maker, they should have the patience and understanding that this is an important piece, but there are other factors while they are like going to make the decision or the policy. So we should be just little conscious. At the same time, making an effort that we need to have this evidence appreciated, recognized, and used by them. Okay, so what is difficult is need for a consensus on research results. Obviously, what happens, like I left US long time ago, but like 15 years ago I was there. So there was almost sort of a race. There was some publication in the New England Journal of Medicine about coffee, and they say it's wonderful. It makes your life so good, rejuvenating, fresh. And then 6 months down the line, Stanford Journal of Medicine say, oh, there's a serious chance that if you take this number of coffee, you may have pancreatic cancer. So people get puzzled. And then, like a year after that, there would be another paper that would say, oh, the probability is less. We have done some sort of longitudinal studies. No, it's not that harmful. Which is the real science? No question. But it is, I think there's sometimes people interpret in the policy and the power corridor in a very different way. So how do we bring that consensus? It is always tough. As the moderator was saying, we are having a discussion about Ebola every day. And there's a battalion of people who are modeling. So there are people who are predicting that it's going to be 20,000 people in December. There are people who are saying 7,000. And there are different modeling techniques. And they're all correct. There's no interest, like personal interest. But somebody who has to make a decision, president of Liberia, or the UN Secretary General, or the DGWHO, we have to bring what is the really like realistic consensus, and that's tough. That's not easy. And you have to make a judgment. It's a judgment call in the end, but based on the science, but bringing a consensus among the scientific community and the policy and power corridor has its own like tussles. And the other is like, there's no evidence that if you have a more evidence or more use of evidence, your policies are going to be better. There's no linear like relationship. And so it does play a role. And if you see the most successful people like Julio Frank, who's the Dean of Harvard School of Public Health, he was Minister of Health Mexico for 2 terms. He is one of the person who was a great scientist, and he has used science to improve policy and the management scene within the government. But he has done some legislation, as the previous speaker was saying, and that has really helped to put the things in place. And historically, the legislation has played an important role in use of evidence and use of research in improved policy. But that factor is never seen as a research side. That factor is primarily seen the responsibility of the parliamentarians. And then there's also like issues, who does really policymakers listen to? Like, it's not real science, but this is what we have, like, there are a couple of publications that they are influenced by values, experience, expertise, judgment, lobbyist, pragmatism. And then in the South, there's a lot of like distortion or pressure from the funders, and whatever they think needs to be funded for the research, they give money because most of the governments don't have the money to have the national research funding. Okay, so what seems to work? No simple blueprint for what will work, and that's the reality. Research projects and programs are more likely to be successful when they are focused on current policy problems and have clear objectives, have specific audience and know their profiles, engage closely with policymakers throughout the process. As I was given the example of Bangkok, if we engage the users or the managers or the policymaker, what sort of research question we have to set and identify, then the probability of acceptance and use is much higher. And then I think it's the communication, which I was saying, like, okay, there's a scientific language, but we have to see what exactly, how can we translate into simple words without compromising on the science. And these are the three, like, sort of things, like, which is like from 3 articles. Policies for health are social choices, and we have to understand that. And that the way in which they are formulated and implemented matter very much in determining either a virtuous or a vicious cycle between a society's level of development and the working of its health systems. So it does not happen in isolation. Other is decisions imply there is a single correct answer. Choice implies that there are a number of correct answers that depend on context and values, and that is what most of the time policy and the decision maker prefer. If you give them a number of choices, then saying this is our recommendation. And then moving from medicine to the management and to policy is increasingly moving from decision to the choices. And historically, we have done very well in the evidence-based medicine, but in the policy, I think we can only have evidence-informed policies and not necessarily evidence-based policies. So, World Health Organization in 2012 published a strategy on health policy and system research entitled Changing Mindsets, and that is where we're saying the policymakers has to change their mindset and the researchers have to change their mindset. And what we have been promoting is embedding of research within decision-making processes in order to increase relevance and timeliness of evidence generated, as well as to ensure greater use of that evidence. Because we believe health system is a learning health system. So the research needs to be embedded within the program and the implementation, instead of saying, okay, there's a separate research somebody is doing and there's a separate user. So it has to be embedded. So there's a demand driven and there's like a natural use once we generate the data or the information, not only for the policymakers, but the program managers, hospital administrators should be like generating knowledge for their own use and improve their systems and the program. So I have just one more slides, and whatever we do, I think we as a responsible citizens, but more as a responsible scientists, ethics is one of the most important things. Like it's either like as a program manager, as a researcher, or as a policymakers. And I have just one slide and then I will go. So this is somebody saying need cash for alcohol research. So thank you very much.